Are present. First order of business is approval of the minutes of May 3rd, 2021 committee of the whole meeting.
So moved.
Second.
It's been moved and seconded for approval of minutes. Any discussion? All in favor?
Aye.
Opposed? Carried. Item 2 on the agenda is a presentation on race, racism, and public health by Paula Tron-Enzio, Mobilizing Action Toward Community Health Group Director, University of Wisconsin Population Health Institute. Ms. Enzio, you can have the floor now.
Thank you so much, and thank you so much for having me tonight. Can I share my screen?
You're on a large screen here.
I think I need some Zoom controls to be able to share slides.
Gotcha.
Great.
Should be set.
Great, thanks so much. I'm just confirming that you are seeing the correct view. Is that right?
We can see your presentation.
Great, thank you so much. As was stated, I'll be talking about race, racism, and public health today, and thanks so much for sending your diversity, equity, and inclusion report in advance. It was great to see that kind of work happening, lots of progress happening at the city level. So again, I'm from the Population Health Institute. We are based at UW-Madison, but have a statewide footprint. So really work in partnership with organizations and community-based groups and leaders all around the state. We are one of 4 units within the Population Health Institute, the County Health Rankings and Roadmaps, our evaluation research group, health policy, and our work really leans into efforts to advance health equity here in our state of Wisconsin. So just to open up, want to offer a broad definition of health, and I think a lot of the slides that I'll cover today will hopefully be repetition, things that you all have heard before. We've been present across the city for several trainings and have seen some of your staff give training. So I hope a lot of this information will just complement things that you already know, but happy for folks to flag me down if you need me to pause or clarify anything. So we draw on a broad definition of health using the World Health Organization definition that health is not just the absence of disease, but really thinking about full well-being that encompasses physical, social, emotional, and mental well-being. And want to offer this particular definition of public health. This is a bit broader than statutory definitions of public health, and we really view public health as what we all do as society collectively to ensure the conditions for all people to be healthy and thrive. So this means that public health agencies are certainly a key part of this picture, but as you can see here, it also takes the work of neighborhood organizations, nonprofits, mental health groups, faith institutions, law enforcement, doctors, hospitals, the whole range of stakeholders across an entire community to think about how we are moving ahead decisions and policies and practices that allow all members of our community to thrive. Some definitions, you'll see a lot of language around disparities and inequity, and just want to offer some specificity around the language of inequity, especially as we think about the field of public health overall. Disparity is what we consider to be an umbrella term. It's a population-based difference in health outcomes. An example is that women have more breast cancer than men. But when we look at disparity data, we can't always tell the driving forces. So for folks that care about prevention, wanting to prevent disease and ensure wellness, it can be difficult to only think about disparities. So over time, the field of public health has offered more specificity when we talk about the language of inequity. So all inequities are a disparity, but not all disparities are inequities. We think about inequities as particular disparities that are based on socially determined circumstances. So things that the stakeholders of the image that I showed you previously make decisions around. For example, we have observed that over time, American Indian populations have higher rates of diabetes due to the disruption of their way of life, due to replacement of traditional foods with unhealthy commodity foods. So this was a particular set of policies that really shaped the diet and food intake of American Indians in particular. So in a patterned way, we have observed that over time, in relationship to this policy, American Indians have increased rates of several chronic health conditions, but diabetes lifted up here. And when we describe disparities as inequities, we get closer and closer to actions, which by definition, inequities are actionable things that we as community leaders, decision makers, and researchers can really hone in on to change, to really promote health and well-being and prevent disease. So health equity then means that everyone has a fair and just opportunity to be healthy. And I'm underlining that word opportunity. I'll pick up on that throughout my conversation today. And it requires us to remove obstacles to health, such as poverty, discrimination, and the consequences related to those conditions. This includes powerlessness and lack of access to good jobs with fair pay, quality education, housing, safe environments, and health care. And this is becoming more and more the standard definition that's shared across the US related to how we think about health and well-being and how we measure our progress towards health and well-being. As I think about defining equity, and this I think mirrors some of the language that's in your report as well, want to lift up the distinction around between equality and equity. And I think this has particular importance for especially those that are making decisions around policies and practices and resource allocation. So these are both concepts of fairness, but equality is really about sameness. It judges whether or not everyone is receiving the same thing. And really this framework can only work well if everyone starts from the same place. But as we know, many of our community members over time are not starting from the same place. So equity is a more appropriate approach to think about how we are shaping policies and practices to assure that everyone gets a shot at the same opportunities, that we are making adjustments to make sure we reflect differences in histories, barriers to participation, and opportunities. Often in my trainings, I get folks that sort of have reflections and comparisons and metaphors. And one training participant shared with me when they thought about this, they thought, wow, it's sort of like parenting. When you have two kids that are, you love them equally, but they are quite different individuals, your parenting approaches need to be equitable and not equal, right? In order to assure that you are being responsive to their assets and their talents and their needs. So while you might love them equally, your parenting approaches with each individual child needs to be equitable in order to ensure that each of those children have all of the things that they need to thrive and be their best selves. So this sort of sets the framework and foundational definitions for the racism is a public health crisis. This work really comes after decades of partnership engagement across not just our state, but nationally, to really think about the role racism in particular plays as it relates to public health. And a few years ago, several of our state leaders came together and said, you know, we're at a point where racism is a driver of public health outcomes that have reached crisis state. And these are some of the key pieces of evidence and rationale that those leaders identified to lift up that statement. That race is a social construction that's not based on biology. It's actually based on how genes express through phenotypes. and that racism is a social system that really implicates many different parts of our community and our societies and our structures, and it structures opportunity based on an assignment of value on how someone looks. So not the internal biological makeup of their persons or their bodies, but how they look outwardly. And this social assignment has created unfair advantages for some and unfair disadvantages for some. And this is patterned across race, which has been sort of socially defined and constructed. We also have observed through many studies, from economic studies to social policy studies, that racism saps the strengths of our societies and wastes human resources through persistent racial discrimination. And we have at least, this was written several years ago, at least 100 research studies, empirical studies, that really links the role of racism to worse health outcomes that are patterned across groups of people. And our data in Wisconsin starkly continue to provide evidence around these patterned outcomes. And this has showed up greatly in COVID-19. It's been a really intense case study that we are still living today on patterned outcomes by race and ethnicity. So here we see cases of COVID-19 being disproportionately bears the burden on our Hispanic and Latinx communities. So in the next three images, you'll see a similar structure on data. You'll see populations on the far left, percent of population, helping us understand proportion, and then percent of all COVID cases. And then the last bubble shows proportionate burden, disproportionate burden. So in this case, our Latinx community members have had the highest cases per 100,000, and that's disproportionate because they make up a smaller percentage of our population. On this slide, you'll see hospitalization data, and you'll see our populations mix a bit here, and our Black Wisconsinites rise to the top with our American Indian community members in second. And you'll see that disproportionately Black Wisconsinites are bearing the burden of hospitalizations, and American Indian counterparts not too far behind. And these are deaths. And again, you'll see our population sort of shuffle around again. And you see here our American Indian residents in Wisconsin bearing a disproportionate burden of deaths. And other than social and environmental and economic reasons that then shape our capacities to access resources and certain behaviors, we know, as our previous studies have shown, in terms of how racism works, that structures these patterns and outcomes across communities, that there were many opportunities in our past that we could have rewritten policy to alleviate this disproportionate burden. And a part of some of the frameworks we use to describe those factors that shape health that are inclusive of health behaviors, but far beyond individual behaviors alone, is our social, economic, and environmental factors. And those things are what we often refer to in public health as those social determinants of health. So where folks live, learn, work, and play. And I think COVID-19 was another example of community members living in some places, playing in other places and jurisdictions, and working in other jurisdictions. Another really stark example of how our fates are really connected, that it's not just about one community serving the residents that live in a place, but also needing to consider who plays in our communities and who works in our communities, and where they go before and after work and play really make a difference on how we collectively can be well. And our pandemic that we continue to be moving towards recovery was a really good example of how, where we live, learn, and work and play is all connected and creating our collective abilities to be healthy and well. And those social and economic and environmental factors all shape our range of opportunities to have choices, and therefore have been shown to shape our ability to make good, healthy decisions, or our lack of abilities in some cases. So how does race, racism, and public health play out? And hopefully you're picking up on a theme here, that those factors that we just talked about, social, economic, and environmental determinants of health, those factors are racialized, and they create patterns and outcomes. And racism is that particular way those health factors are racialized. So racism is a system of, again, structuring opportunities and assigning value based on social interpretation, and again, creating different advantages and disadvantages on a population level in a patterned way. And this shapes, as you can see from this image, most, if not all, of our policies, laws, and practices that shape our everyday lives. So none of us are immune from the impacts of these racialized systems. And at its heart and its core, these racialized systems are creating communities of opportunity, which consistently lead to good health, and communities of low opportunity, which consistently lead to poor health. And we've been observing this in our communities for decades, right? The field of community development has been studying for a long time what creates vibrant communities. So when we look across literature and compare that and complement that with public health literature, we know very well that when we shape communities of opportunity, our communities are not just healthier, they're more vibrant, they economically thrive, there's better jobs, there's stronger social cohesion, social connectedness, and our low opportunity communities structured by policies fare worse on those short-term outcomes as well as our health status. And all of these systems have multiplying effects. So as a person walking in the world, we experience our transportation systems, our lack of a sense of belonging, segregation, housing, crime, poor quality education, lack of access, and often for communities of color, racism and other forms of discrimination. These arrows demonstrate that these individuals and populations experience these systems and aren't able to access the services and resources of those systems, but also the interaction with these systems cause stress. When you're interacting with systems that decrease your sense of belonging, that segregate you from others, when you're interacting with systems that have poor quality education, it's not just the system that's impacting you, it's also the stress response of interacting with those systems. So there's multiplying effects that eventually get under our skin and causes what we call in public health and health research chronic toxic stress. And this is starting to be studied widely. It's at the root of how we understand adverse childhood experiences, or ACEs, to create long-term trajectories of trauma in kids and in community members and populations. One metaphor that I like to use just to sort of illustrate that feeling of stress is driving in a blizzard. I don't know how many of y'all have ever been stuck on a highway needing to commute, on an hour drive, and the blizzard starts and things get slippery, your windows start fogging up and you can't see. So that white knuckle driving gives you a sense of that stress. Some stress in our lives is healthy for us. That fight or flight reaction keeps us safe. But if you continue to experience that stress over long periods of time, that gets under our skin again as toxic stress and begins to have physiological impacts on our bodies and our systems. And if you can imagine, if you're going through a really stressful time at work, that's when you're more likely to get sick. And if you get sick, you stay sicker longer. And you feel more sick, and it's harder for you to get well. And that's that constant persistent stress, that constant vigilance, or that constant white knuckle driving that you can't get out of. It begins to build up in our systems. And what we understand to be the Life Course Initiative is that this chronic toxic stress can also be passed down from generation to generation. If we do not mitigate the impacts of that kind of stress or trauma in one generation of a population, it does indeed get passed down. And this is what we've been observing for American Indians in the US who have experienced historical trauma that lives on today, and for Black Americans that are descendants of slavery continue to experience systems that are reproducing racism on a mass scale. So our opportunity, as we are observing right now in this moment, and as we've been building up to this time over the last many decades, is what we're striving for, especially from a public policy perspective, is thinking about policies of inclusion. Those policies that create low opportunity communities are what we can consider policies of exclusion, excluding particular communities from opportunity. So we can learn a lot, especially by looking at what happened with the disabilities rights movement, which continues today around curb cuts, for example. That curb cuts aren't just good for folks with disabilities, but they're good because they are policies centered around inclusion. And it's not just folks with disabilities that are benefiting, it's also families, those that are traveling with luggage, those that are pushing strollers, pushing grocery carts, that have a wide range of benefits. And similarly, if we can focus our thinking around policies to center inclusion, that is good for communities of color, certainly, but we've also observed that these policies are also better for families of all shapes and sizes, supports local economies, supports folks to age in place and have access to livable communities, those experiencing poverty, those with disabilities, those that have access issues to resources such as transportation, for women, those that are LGBT, youth, those experiencing mental health, and certainly has good outcomes also for our planet. So sort of coming back full circle, wanted to offer again the language that supports the justification of the racism as a public health crisis declaration. I've included some of those links for the sign-on information on our website. And we do ask that as folks sign on, that these are declarations are incredibly important, and we view them as a place to start and continue work around actions. So do list actions for organizations and coalitions as well as for individuals. So I know that was a pretty high level overview. I know you all have done a lot of work in West Allis, so want to also respect your wisdom and expertise, and happy to take questions or listen in to throughout this agenda item.
Thank you for your presentation this evening. It's given us an opportunity to review the many programs that we offer to our low to moderate income residents and to seek new areas to assist the less fortunate than us. I had requested staff to document our initiatives to address the underserved members of our community and list some of the future goals that we have. I believe you were sent a copy of that presentation, as were all of the older people. It's a good reminder for all of us the need of the services that many people in our community have. Some of these programs have been initiated in the past several years. Others have been going on for literally decades. Our staff has done a wonderful job of bringing available federal and state grants and programs to our attention so that our residents can benefit from them. We have an active community development block grant committee for many years. Those funds have been used for such things as lead paint abatement, home security measures for low-income residents, ADA accessibility, home improvement loans and grants, and many other programs too numerous to mention. We have used HUD, Housing and Urban Development Home Funds to build new homes for low-income home buyers. We have economic development loans and grants to help minority and low-income entrepreneurs. Our health department provides nutritional and wellness support to high-risk families, in addition to addressing substance abuse, mental health, and promoting healthy lifestyles. We have an abundance of affordable housing in West Dallas and have a number of initiatives to ensure the maintenance of our housing stock. We look forward to continuing these and expanding these efforts as new programs become available. We are not newcomers to the field of helping minorities and the underserved in our community. We've been doing this for many years, and we welcome any new programs that are brought to our attention. Our staff has really done a good job of this. Our one problem is, as a city, we have limited resources to do things on our own, so we rely heavily on state and federal funds and programs to do this, but we certainly take advantage of those programs when they're available. Thank you. Any other comments or questions?
Mr. President?
Alderwoman Keene.
Yeah, I just wanted to also, this did bring light on actually a lot of the initiatives that we have, and I feel that we have a very good base. I mean, just a few is the Complete Streets policy, where the city is committed to fostering a livable city through the creation of complete streets that improve access to neighborhoods, prioritize safety and health for residents and visitors, support economic growth, improve access to education and jobs, enhance urban design, encourage physical activity, reduce negative environmental impacts throughout the city. We recognize that a safe, reliable, and comprehensive transportation network is right for all residents and visitors to West Dallas, regardless of ability, age, gender, race, ethnicity, income, and et cetera. Being part of the Community Block Grant Committee, I felt it was important to kind of call out some of the items that we do. I know Alderman Lysak kind of touched on it, but we do have the supporting family strengthening community, where we alone set aside 16,000 program goals to connect low, moderate income families with necessary resources, provide services to assist in optimal development and school readiness skills for children under the age of 12. We also have the housing rehabilitation to help lower income with first-time homeowners with down payments, to help rehab the outside of houses. We have a Milwaukee County Outreach Services that we set aside $30,000 and focus to assist 30 individuals facing homelessness with case management, housing search, engagement. I'm not going to go on and on, but we have the healthy homes with the lead abatement, providing nutritional meals, the WIC program. So we have a lot, and I really want to applaud the city for what has been done. I'm not saying we can't maximize. I do think one thing we can focus on is potentially more education, so our residents are aware exactly what they have at their fingertips to truly take advantage of these programs. But I will say that I do feel West Dallas has done a good job. Doesn't mean we're finished and we can't maximize on what we already have, but I did want to applaud where I feel we are at.
Anything else come before the committee? Hearing none, thank you for your presentation. Is there a motion to adjourn?
Motion to adjourn.
Second.
Any discussion? All in favor?
Aye.
Opposed? Carried.